Good afternoon and welcome to our third ACA NY LifePlan CCO New York provider webinar, the LifePlan Development Process. My name is Megan Porter and I am the Director of Provider Relations for Metro and Staten Island. Our presenters today are Nadir O'Brien, Director of Provider Relations for Hudson Valley, Renee Manza, VP of Care Management for Hudson Valley, Metro and Staten Island, and Karen Santi, VP of Care Management for Central New York and Southern Tier. Thank you for joining us. Today's presentation will discuss the development of the LifePlan in detail with the goal of providing a deeper understanding of the process. To begin, it's my pleasure to introduce Nadir O'Brien.
Today's presentation is divided up into 4 sections: the importance of the LifePlan, preparing for the LifePlan, review of the LifePlan, and after the LifePlan. At our last webinar, we covered the comprehensive assessment process. Before the LifePlan review, care managers review supporting documentation such as the CAS, CANS, DDP-2, and the LCED and get updates from family and providers. The care manager updates the past assessment using information gathered and current knowledge of the member. This person-centered planning is at the heart of each assessment process. Information gathered from assessments is used to develop a member's LifePlan. Now, we will progress into a discussion of the LifePlan itself. Why is a LifePlan important? The LifePlan is important to our members because it helps to build and provide a picture of who they are. It is a chance to review and refine the information captured reflective of the member. The LifePlan is a prescription of services that identifies the member's service providers, goals, and safeguards. The LifePlan highlights strengths and preferences and provides for a discussion on areas of needs and gaps in services. It is a process where care managers must integrate the elements of the delivered 6 Health Home Core services into the member's LifePlan, which are comprehensive care management, care coordination and health promotion, comprehensive transitional care, individual and family support, referral to community and social supports and services, and use of health information technology to link services. And now, Karen will discuss preparing for the LifePlan.
Thank you, Nadira. As we have learned, the PATHS assessment is to be completed at a minimum of annually. About 2 to 6 weeks prior to the annual LifePlan review, the care manager will review the PATHS assessment with the member and representative and other members of the interdisciplinary team. To prepare for the LifePlan meeting, the care manager will have collaborative discussions with the member and their advocate and any providers. This is a time to catch up and prepare for discussions that will be held at the LifePlan meeting, including changes the member may want to make or any new information that needs to be added to the conversation at the LifePlan review. As discussed previously, the care manager will review the DDP-2, the PATHS assessment, and the staff action plan. They will also review the LCD, CAS, CANS, and most current physical. At this time, the care manager ensures that all information is correct and consistent across documents. All of this information will commence into a draft LifePlan that they will bring to the meeting for each team member to review. The care manager will work with the member and their team to identify who should be invited to the LifePlan meeting. The care manager will invite anyone the member wants to be a part of their team and should even suggest inviting medical and/or behavioral providers. At the very minimum, the interdisciplinary team includes the member and the representative or actively involved family or friend, the care manager, and a representative from each waiver service. Many providers wonder how soon they should expect an invitation to a LifePlan meeting after their availability is confirmed. Ideally, all providers should receive an invitation to the LifePlan review meeting about a month before the next LifePlan review meeting should occur. Providers should expect to receive an email confirming the date, time, and location of the LifePlan review meeting. This email will be sent to the member, the representatives, and their interdisciplinary team. Providers should expect to receive an updated draft LifePlan when receiving this confirmation email. The LifePlan meeting should be conducted at a time and a place that is comfortable for the member and that maximizes the attendance of their team or circle of support. The life plan meeting should take into account any cultural considerations of the member. Is an interpreter needed? The information discussed must be provided in plain language and in a manner that is understood by the member and the member's chosen participants. This is a good time to avoid acronyms. Providers should allow at least an hour for the meeting. The plan for allotted time should be reflective of how much information needs to be covered and the member's needs. Is it an involved self-direction plan? What is the member's tolerance for sitting through a long meeting? Do they need to get up and walk around a bit? If it is held at an IRA or a day program, every attempt should be made to ensure the member's privacy and comfort, as well as consideration for transportation to and from the meeting. The member should always be present. If a member is not available that day, even at the last minute, did they accidentally take a cab home from Dayhab instead of waiting for the meeting? Then the meeting would need to be rescheduled. Planning and communication is very important to ensure things go smoothly. It is the responsibility of the care manager to support the member, to facilitate their meeting to the extent possible, and to ensure that all information is gathered from habilitation providers and reviewed. The life plan meeting should be member-led meeting as much as possible, and the member has the option to choose a member or a person to facilitate the meeting. The member should have input as to what is discussed. If there are subjects that make the member uncomfortable, these subjects can be discussed at another time with members of the team with whom the member feels comfortable talking to about those topics. Providers are very important members of the team as they are positioned to know crucial information and updates regarding the clinical, medical, and health status of the members they support. They also have specific insight into the member's daily activities and topics discussed in their day-to-day life. Has the member discussed wanting to do something else, such as work, a volunteer job, or a hobby? Well, providers should be prepared to share all information with the team on staff action plans, areas of changes in strengths and needs, supervision levels, safeguards, as well as rights modifications and any reasonable accommodation that is or will be needed. These discussions can happen prior to, during, or after the life plan meeting to support the development of a comprehensive person-centered plan. The interdisciplinary team will meet for the first time when the member is initially open to care management services. For new enrollees, the care manager must complete a life plan within 90 days of enrollment. After the initial meeting, the team will meet at minimum twice annually to complete the annual and semi-annual life plan meeting. It is our best practice to have the semi-annual meeting 6 months after the annual meeting. The team will also meet whenever there is an acute change in the member's condition, including social, health, or behavioral changes, or at the request of the member to discuss questions, concerns, needs, or if there is a transition of care or change of provider responsibilities. An addendum should be completed whenever there's a significant change. If a life plan review has to be canceled due to the needs of a member, it can be rescheduled and the life plan will not expire until a new life plan is put into effect. The sections of the life plan are as follows. Section 1 is the assessment and narrative summary. These are the narratives that build a whole picture of the member. Section 2, objective and support strategies. This is where goals and supports are discussed. What does the member want to accomplish? What support do they need to meet their goals? Section 3, individual safeguards, individual plan of protection. What supports are needed to help the member to be safe, including individual backup plans and strategies. The document changes as the needs of the member changes. Section 4, home and community-based services, waiver and Medicaid state plan authorized services. This is where all home and community-based waiver providers are listed along with any provider who is paid for by Medicaid. Section 5, all supports and services funded, natural community resources. This is where we would add family support services, ISS, and any community resources the member utilizes. There's a line for member and representative approval, and then section 6 for acknowledgments and agreements from providers. Now we'll discuss the narrative profile section of the life plan. The narrative sections of the life plan are comprised of 7 subsections: introducing me, my home, let me tell you about my day, my health and medications, my relationships, my happiness, and my school and learning. Introducing me. This narrative must include a thorough and person-centered description of the member. It should describe the various areas of a member's life, including an introduction of the member by identifying their name, age group, preferred nickname, how the member communicates, and if they are self-advocating. If the member is not able to advocate for themselves, then the narrative should include who the representative is and how they assist the member, such as with person-centered planning, decision-making, and approving the life plan. This narrative should also include the member's strengths, preferences, challenges, needs, interests, abilities, and skills. The member's goals, desired outcomes, hopes, and dreams should also be incorporated. In this narrative, there should be an explanation for the need for services, and a justification for each approved service should be included. This is especially important to providers to ensure services can be approved. This section should also include information and cultural considerations, including language access needs, religious associations, lifestyle preferences, and community membership and participation. If the member would like to vote, their voting status can be included along with how much support they need to vote. If the member is a Willowbrook class member, it should be noted here, and generally speaking, the narrative needs to clearly outline the person's preferences as well as places in the community which the member likes to frequent. Lastly, there should be an explanation of the need for each state-paid and non-habilitative waiver service, such as other than paid services, individual directed goods and services, and family reimbursed respite. My home is the next narrative. This narrative has a different requirement based on whether a member lives in a certified or non-certified setting. If a member resides in a certified setting, the My Home narrative must include whether the home was chosen by the member, if they have a choice of roommates, and if the member has the freedom to decorate their room as desired. This narrative should also focus on if the member has a key to their home, if they can access food whenever they want to, if they are able to have visitors as desired, does the member have access and support to be involved in their community, does the member have control over their personal resources to their best extent possible. In this section, we can discuss if they are happy with their living situation. Do they want or need a change? We will also discuss any rights restrictions. Is the rights restriction for the member or for a roommate? This narrative will include any clinical justifications, previous positive and less intrusive interventions, evidence of the specific supports, and review of data related to the effectiveness of the interventions, time limits, and review for the continued necessity. We need to discuss actions to ensure the interventions cause no harm and that the member has given informed consent to the rights restriction. This section also includes information from the member's behavioral support plan as it pertains to the rights restrictions. If the member doesn't live in a certified setting, the My Home narrative should include a good description of the member's home and living situation. Who do they live with? Are they happy where they live? This section should also discuss whether the member is interested in different residential opportunities, and if so, the type of support they would need. Let me tell you about my day. This narrative talks about the person's daily activities. Do they have a job? If so, where do they work? What support do they need to maintain their job? If the member is not currently working but wants a job, then the Let Me Tell You About My Day could include how they plan on getting a job, what supports and services they need, what job skills they have, and what type of work they want to obtain. If the member does not work and does not have any desire to work, then this section would discuss why the member chooses not to work, any fears or concerns they have about working. This is where you will see information about day or community habilitation services and any routines, volunteer work, etc.
The My Health and My Medications narrative talks about the member's overall health, how they feel physically and mentally, and what is needed to keep the member healthy and safe. What is the member's diagnoses and their implications? It will also include the members' priorities related to their health concerns and medical needs, any allergies they may have, along with any precautions related to them. Any setbacks or accomplishments related to the member's health and any medical aids, such as vision or hearing aids. This section defines any risk factors and takes into account the member's right to take some personal risk. This narrative also includes a review of the member's fire safety and evacuation needs. If the member lives in a certified residence, a statement about whether or not the fire safety needs are documented in the residential IPOP or staff action plan, and if they are appropriate. If they live in a non-certified residence, there should be information regarding the care manager monitoring to ensure if safety needs are being met. This will include supervision level specifics, evacuation ability, and supports needed. Any adaptive equipment or environmental modifications needed to safely evacuate in an emergency will be included here. Confirmation of the presence of fire safety equipment, such as smoke and carbon monoxide detectors and fire extinguishers, evacuation plans, and training received or needed regarding how fires are started and prevented. This narrative will also identify any advanced directives in place for the member and if informed choice was given on them or any follow-up needed. For Willowbrook class members, it must also indicate hospital coverage during cases of hospitalization. Lastly, this narrative will include the status of the member's OPWDD eligibility, that a current LCD is on file, that the member's Medicaid is active, and that the member has agreed to be part of the CCO health home by signing the appropriate Department of Health consent form. There should also be a statement of the status of the member's CAS or CANS assessment, including the date of any assessment and reassessments and details about any discrepancies. The My Relationships narrative describes the most important people in the member's life. Who does the member like to be with? Do they have family and friends they like to spend time with? How often and how do they spend time with them? Are they connected with people in their community and their IDT or circle of support? How often are they in contact with people who provide support in their lives? What type of support is provided and how is it provided, in person or over the phone? If the member is a Willowbrook class member, this section must indicate if the member has Consumer Advisory Board support and what level of support the CAB provides. It must also indicate all family involvement. The My Happiness narrative describes how the member feels in general, as well as what makes them happy, mad, sad, and frustrated. This is where we talk about how the people in the members' lives can make them feel better. If the member is nonverbal, how do we know if the person is happy or sad? Challenging behaviors and triggers will be noted here, along with strategies for working with challenging behaviors. Do they have a behavior support plan? What types of things can be done to alleviate any challenging behaviors? Here, the person can talk about their own challenging behavior, including what helps them feel better. In the meeting, the team should be very sensitive to the person's feelings about how we discuss these behaviors. The final narrative is My School. This narrative provides information about the person's educational setting and accommodations needed for success in the school setting. Transition planning is discussed here, including what the member is interested in doing after high school or college. If the member is not currently in an educational program, then this section would include educational history, accomplishments, goals, aspirations, the member's interest in continuing their education or not, and the types of educational programs they have an interest in, such as art lessons, cooking class, or driver's ed. And now, Renee will discuss sections 2 through 6 of the LIFEPlan.
Thanks, Nadira. Section 2 contains the member's goals and outcomes. Items listed in this section may be designated as goals, supports, or tasks, and each item is assigned to a provider, natural support, self, or a care manager, and should specify what the expected to be done for the member to achieve their goal or valued outcome. When assigning provider-assigned goals, the care manager uses the team approach with the member in the driver's seat. It's important for the care manager to work with providers to ensure that the plan is capturing not only the goals that are important to the member, but also that the goals are being worked on in the way that the member wants to work on them. Care managers should be working to review the member's progress towards the assigned goals and talk about any barriers. If the care manager notices a member has been working on the same goal with little progress, there should be an open discussion with the member and the interdisciplinary team to discuss if this goal is something the member truly wants to work on. It's important that all members of the care planning team are included, engaged, and working together towards the ultimate outcome of a comprehensive person-centered life plan that meets the needs, safeguards, and goals of the person. This section identifies what services and goals the provider has agreed to. They should be personal outcome measure or POMS driven. Some things to consider when developing goals in collaboration with the provider. Does the person live and receive services in the most integrated environment? Does the person have community participation experiences that are meaningful to them? Does the person have meaningful relationships with friends, family, and others that are important to them? Does the person experience personal health, safety, and growth opportunities? Does the person exercise choice and decision-making in their life and with their daily schedule to the best extent possible? Section 2 of the life plan should be broad and overarching while still accurately reflecting the goals that are most important to the member. The staff action plan will provide details on what specific actions a provider will do to work toward the goal of the member. Therefore, it's imperative that the creation of the goals in Section 2 remains a collaborative process for all providers that are anticipated to provide the service. Similarly to the slide above, Section 3 of the Life Plan contains the safeguards that must be in place to support the member in maintaining desired personal safety, reduce the likelihood of harm, and promote good health. This is done through supports and should match the information that is noted in the narratives of the life plan. The care manager works with the IDT to discuss levels of supervision at home as well as in the community, supervision overnight, the ability to evacuate in the case of an emergency, call for help, fire safety, medication administration, eating guidelines. Some examples of that include maybe a specific diet or a food allergy or a choking hazard. It's important for providers to work closely with care managers to ensure that levels of supervision are accurate for the services that they are rendering. There may be more than one provider assigned to a safeguard or multiple safeguards for varied providers. An example of this might be the level of supervision a person receives at home versus what level of supervision they receive at day program or even out in the community. Section 4 lists HCBS waiver services, and Section 5 lists all supports and services, funded and natural and community resources. The information for all providers providing waiver services is linked directly to choices. The effective date of the service will be the date that the provider submitted a DDP-1 to enroll the member into their program. It is imperative that providers review this section to ensure that all the information noted is accurate. Aside from waiver information, this section contains all natural supports, so parents, guardians, advocates, other family members, etc., community resource contacts, so HCBS waiver provider representatives, support staff, or maybe some other helpful community members, and other providers such as primary care physicians, other medical contacts, hospitals, pharmacies, etc. As discussed earlier, the care management regulation is that the life plan must be reviewed twice in a 365-day period through the end of the month in which the last day of the life plan effective date is noted. As an example, if the life plan's effective date is 5/15/2022 to 5/14/2023, the care manager may have the annual life plan meeting scheduled up to May 31st, 2023. It's important to note that care management regulation, but from a provider perspective, it's important to note that the life plan does not expire until a new life plan is put into effect. The annual life plan must be done with the member in person and typically done at the member's day program or residence or in another location of the member's choosing. The semi-annual life plan is encouraged to be in person with the member as well, but can be done through telehealth if it is the member's preference to do so. In the event that the member's representative is unable to attend in person, or if all service providers can't attend in person, the care manager will facilitate other options for the team to participate, such as Microsoft Teams or other approved platforms. Care managers must make every effort to coordinate the life plan meeting so all providers can participate in that meeting. Providers should expect an invitation to the life plan in advance for both the annual and the semi-annual reviews. Aside from the review of the life plan document, care managers also review other items with the member and/or their representative. This includes consent forms to ensure that providers are all noted accurately, OPWDD rights packets that describe member rights, and the person-centered planning notice as examples. During the life plan meeting, it is the role of the care manager to ensure that all participants understand the purpose and process of the meeting. The care manager is expected to lead the discussion and ensure that all people in attendance have introduced themselves and are ready to participate in the discussion regarding the member's life plan with the member and their representative. To help support the discussion, the care manager may ask questions about whether or not the current services are helping the member meet their goals, if there's anything the member wants to change about their current services, what parts of the member's services are most helpful to them, are there services that the member is not receiving that they would like to receive, and what services is the member receiving that they are happiest with. This will help the care manager and the team to assess if the member is satisfied with their existing services or if there are gaps in that the care manager and team should explore and what else the member might need. This is also an opportunity to discuss whether the member wants to self-direct any of their services. During the life plan, the care manager, along with the IDT, discuss and address any significant life changes that might be occurring and have a robust discussion on any concerns that are noted. Although a sensitive topic, it is also the expectation that the care manager review advanced directives such as future planning, power of attorney, healthcare proxy, MOLST information, and burial account information as well. The member and/or their representative can decline to have the conversation on these items, but the care manager should attempt to educate the member on their importance and continue to revisit at future life plan meetings. Upon conclusion of the life plan meeting, the care manager is expected to make all appropriate updates to the life plan. The life plan effective date is the day the meeting occurred. The care manager will then document the meeting in the life plan in the IDT, summary and comments. This section is meant to be as comprehensive as possible to summarize what occurred at the meeting and should include the date and time of the meeting, the location and method in which the meeting was held, who participated in the meeting, and the level of participation of the member. It should indicate the conversation that occurred in relation to the progress on goals and services, satisfaction of services inclusive of discussions around adding, removing, or continuing goals. It should indicate a review of the appropriate health home consents to ensure all providers and natural supports are indicated correctly and match the providers noted in the life plan. It should also discuss the member's preference for in-person versus telehealth visits if they're a Tier 4 member. If the member does not have the ability to provide consent and has no natural supports to provide consent, the IDT should also indicate the need for the CCO member representative committee to support life plan finalization. The care manager will then make any edits to the narrative sections of the life plan, as well as ensure that all goals and safeguards discussed are noted appropriately. This should be done timely so that all parties have adequate time to review the draft life plan. The draft life plan is initially sent to the member and/or the representative for review in the method in which they determined during their life plan meeting. The draft life plan may also be sent to providers in advance to finalization. However, acknowledgement and agreement will not be requested at this time. If changes are needed to the life plan, the care manager is expected to make those changes in a timely manner and return to the member and/or representative for finalization. Finalization, the term used for publishing, must be done by the 45th day from the life plan meeting. Finalization occurs when the member and/or their representative approve the plan. There are some instances in which the care manager is unable to finalize within 45 days, and it is expected that the care manager continues to make every effort to obtain approval. Some examples of this might include when a Willowbrook class member has full representation from CAB and is pending their approval, or a member without the ability to provide consent has a representative that has not responded timely. ACA-NY and LifePlan CCO also have member representative committees to support the finalization of life plans in the absence of a representative when the member can't consent to their life plan. Upon receipt of finalization, the care manager will then send to all providers and will then seek acknowledgement and agreement to provide the services and goals noted in Section 2 and the safeguards noted in Section 3. This is done electronically for electronic signature as the preferred method. However, there are alternate methods to obtain in the absence of the appropriate technology. Should any issues be noted with the goals, safeguards, or service listings, the provider can request an addendum to the life plan to ensure accurate reflection of these items. Upon receipt of acknowledgement and agreement and the signed staff action plan, the care manager then distributes the life plans to all appropriate IDT members. Staff action plans are crucial to outlining the goals, supports, and tasks that are discussed at the life plan and dive into a more detailed plan on how those goals, supports, and tasks will be implemented that are specific to the service that is being provided. There can be several staff action plans per member, dependent on the number of habilitative services the member receives. The goals in the staff action plan must fall under the umbrella of the broader goals that are indicated in the life plan, and although they do not need to be word for word, they often are. Habilitation providers are required to provide the staff action plan by the 60th day after the life plan meeting as per regulation. However, if the care manager receives the staff action plan in advance to that, it assists in ensuring that goals that were discussed at the life plan meeting are represented appropriately. A signed staff action plan can also act as acknowledgement and agreement from the provider to provide the assigned goals and safeguards in the absence of the preferred method of acknowledgement agreement noted earlier in the presentation. So what happens when you don't agree? Sometimes what's discussed at the life plan meeting might not make its way into the plan, or a member representative might request a change that the provider can't accommodate or doesn't agree with. First, speak with the care manager. Many issues can and are resolved directly with the author of the plan. If after speaking with the care manager you were unsuccessful in resolving the issue, reach out to the care manager's supervisor. If you don't know who that is, you can contact the customer service center for either organization to obtain that information. You can continue up the chain of command until your issue is resolved. Aside from this, each organization has their own formal dispute processes that would formally document within the life plan, supported by our member relations team. The life plan is an integral document that outlines the services a person needs, is receiving, and the supports they need to reach their goals. The life planning process is member-led collaboration with the member and their representative, as well as provider organizations, with the goal of ensuring that the members' identified goals meet their needs and that they are supportive and effective. To wrap up the life plan review process, life plans must be reviewed twice in a 365-day period. Life plan meetings should be scheduled well in advance. All life plans must be finalized within 45 days of the life plan meeting. All required member and or representative approvals must be received before the life plan can be finalized. The finalized life plan must be sent to any providers that are required to acknowledge and agree to the life plan. And now I'm going to hand it back to Megan to close us out. Or really, Nadira is going to do our closing remarks for us.
Thank you, Renee. Thank you again for joining us today. As noted at the start of the webinar, we will post a recording of today's presentation and a Q&A on both the ACA NY and LIFEPlan websites in the next few days. As a reminder, the Directors of Provider Relations are here and available to assist you with any questions and concerns you may have. Coverage areas and contact information for each director is available on the provider page of the ACA NY and LIFEPlan websites.